Before beginning the procedure, the patient history, physical exam, and prior imaging studies are reviewed. The procedure is discussed with the patient and informed consent is obtained. 2 arterial sheaths are placed in the femoral artery as detailed in other procedures consult videos. The intracardiac echocardiography, or ICE catheter, is inserted in the left femoral vein sheath. Using fluoroscopic guidance, the ICE catheter is advanced into the right atrium. Position is confirmed with measurement of right atrial pressure. With the ICE catheter in the right atrium, transducer position and orientation is adjusted to obtain standard views of the tricuspid valve, mitral valve, interatrial septum, superior vena cava, and a short axis view of the aortic valve. The atrial septum can be better visualized with slight posterior deflection and clockwise rotation of the probe. Frequently, the descending aorta may be seen beneath the left atrium in this view, with an esophageal stripe visible between the descending aorta and the left atrium. This ICE image demonstrates an atrial septal aneurysm. Color flow does not demonstrate any flow disturbance or shunt. However, a saline contrast study while the patient performs a Valsalva maneuver shows passage of microbubbles from right to left across the interatrial septum consistent with a patent foramen ovale. These images from a different patient with a secundomatrial septal defect show how ICE is used to visualize the defect, measure defect size, and assess the rim of tissue around the defect. A guide wire is introduced into the other femoral sheath and advanced under fluoroscopy to the right atrium. Once at the septum, the ultrasound image confirms the wire's position at the fossae ovalis, and the wire is passed across the patent foramen into the left atrium. The multipurpose catheter is advanced over the guide wire into the left atrium, and position confirmed by measurement of left atrial pressure and oxygen saturation. Heparin is now administered. The catheter is advanced into the left upper pulmonary vein and oxygen saturation measurement is repeated. A balloon catheter is opened, flushed, and inserted into the left atrium. Under fluoroscopy, the balloon catheter is advanced across the interatrial septum. The balloon is slowly inflated with a contrast solution and visualized on fluoroscopy. Clear-cut waste is seen in the balloon due to the atrial septum. Ultrasound confirms the balloon's correct position across the fossae ovalis, and the size of the balloon waist is measured. The balloon position is checked with ultrasound and fluoroscopy, and absence of shunting is confirmed by color Doppler and with a saline contrast study. Based on these measurements, the specific device and device size appropriate for this patient is chosen, prepared, and attached to the delivery system. The device is submerged in saline and pulled into the delivery catheter before insertion. The delivery catheter is now inserted into the delivery sheath. Using fluoroscopic and ultrasound guidance, the delivery catheter is positioned across the atrial septum. Now the device is advanced into the left atrium and the left atrial disc is deployed. Once the left atrial disc position is confirmed, the right atrial disc is deployed. With both discs deployed, oxygen saturation in the left atrium is noted to increase due to closure of the right to left flow, and right atrial pressure is again recorded. A saline contrast study is repeated at rest and with Valsalva release to test the occlusive nature of the device. Unfortunately, a small superior leak is still present. The decision is made to recapture the device and place a slightly larger one. The device is recaptured into the delivery catheter under fluoroscopy. The new device has been prepped and its action demonstrated by the operator. It is then screwed onto the delivery catheter and readied for insertion by capturing it into the delivery catheter. The device is then introduced into the delivery sheath and advanced across the atrial septum under fluoroscopy. It is then delivered into position. Its position is confirmed with ultrasound. The device is unscrewed from the delivery catheter, and the images show the catheter disconnect from the device. With the fluoroscopic and ultrasound images showing good position, a saline contrast study is repeated at rest and with Valsalva release. A marked improvement is seen over the baseline studies, and the procedure is felt to be a success. A final ultrasound assessment is performed, followed by fluoroscopic assessment. The procedure is complete.